I am Donna Kane, and I'm the chair for Ohio TTN. Welcome. We're so glad you're here. We have a great program, and we thank you for joining us. I did want to announce a couple of things. One is we have the new members group that started meeting today. I know there were a couple of people that couldn't make it because their schedules are just as full as mine. And the rest of the people, there were like 6 people that attended, and it was a very good meeting. And we decided to allow any new members to join, or any new members that hadn't been able to join today that would be able to join in the future. So that was a decision we made today. Also, the program that was Brenda Morris's idea, the poetry workshop from Ohio's Poet Laureate, is now 25 people are registered for that. So there's only 5 spots left, and there's a waiting list. So if we have more people, then we will schedule another.
So Donna, you froze up when you named what the program was. And it's
okay.
The poetry workshop. So
yeah, the poetry workshop on January 24th. There's 25 people signed up. 5 people there's 5 slots left. Okay. I think I've done what I'm supposed to do. So I think I'll turn it over to Carol Oswald.
Okay, thank you.
Mm-hmm.
One little bit of administrivia. There's someone on here called Owner. If you would update and let us know who you are, that would be appreciated, so we can at least see a name. Also, we have a couple of folks who are guests, and I just wondered if you would mind introducing yourself and just quick sentence on how you found us. So I'll go to, is Carol on here? Did she drop off?
Menge?
Yeah.
Yes. Hi, I'm on your mailing list, and I had come to one of your meetings, and thank you for having me.
Great. So that's helpful to know that when people are on our mailing list, they read it and they actually get interested in joining us at some point. So thank you, Carol. You're welcome, and hope you'll come back. And then Angela, if you could introduce yourself, that would be great.
My name is Angela. I believe I have some background noise, so I apologize for that, but I'm very interested in the topic, and I've attended an event with Susie before. So thank you.
I'm sorry, I couldn't. You've attended what?
A previous event with Susie Collins.
Oh, great. Thank you. So you found us through Susie. That's good to know. Okay. The subject today is obviously a really important one to all of us. And I was able to participate in a previous presentation that Leslie did. It was hard to believe it was going on 2 years ago. I think we lost a couple years here, and with all of the pandemic stuff going on, you forget how long things are. But I just so resonated with her presentation. The timing of it has always been great, because the last time I saw it 2 years ago, 3 days later, I had my mammogram for that year. And the following week, I had an appointment with my brand new general practitioner. So I had all of Leslie's data, and I mammogram out to be perfect. So I contacted Leslie and I said, this is such an important topic. Would you be willing to do it again? And we landed on today's date as the right timing for her to join us again. So thank you, Leslie, for participating. And Dr. Kinney also was part of that presentation. And of course, you know, him and Leslie working as a team works out to be really great, and adds to the information that we can get. And so I appreciate both of them being willing to take their time this evening to present to us. I'm going to turn it over to Leslie and to Dr. Kinney to do more detailed introductions of themselves. But I did want to let you know that a lot of this information will be available through Leslie's website. She actually has launched a nonprofit to help communicate all of this information and keep the information exchange going. And so she'll be talking about her website and her nonprofit as we go through this presentation. So I just wanted to alert you to that. So Leslie, I'll turn it over to you and Dr. Kinney and let you guys give your own background information and get the presentation started. Thank you.
Okay, Dr. Kinney, would you like to just go ahead and introduce yourself and then I'll share screen and get started? We'll do it that
Great.
way?
Sure, sounds good. I'm Dr. Michael Kinney. I'm a retired breast surgeon, retired from clinical practice, but I didn't necessarily want to just go away. The breast cancer is certainly still a cause that I'm eager to be involved with. And I did a lot of breast imaging in my practice. Although I was a practicing surgeon, I did a lot of my own imaging, including some functional imaging, similar to what we're talking about today. And I've stayed on with that as a medical advisor for a company. And that got me introduced to Leslie. And we've done a number of these talks together, and it really turns out well. And it's always a pleasure to work with Leslie and spread the word.
And likewise, Dr. Kinney. So I'm going to share now. Hopefully. Yes, we'll get started. Can you guys see that? Is that all good? Yes. Okay. So thank you very much, Carol and the rest of the Ohio chapter, for having us. I've spoken to several TTN chapters now, and it's always a pleasure. And the questions afterwards are always insightful and good. So we look forward to that. So, I'll tell my story. I'll tell you what My Identity Matters does and what that can mean for you and your friends and your family. And then we'll stop the presentation and there will be time for questions. That's where the good stuff happens, the questions. So it all started over 5 years ago now, believe it or not. November of 2017, we were just going along like normal people, nothing very interesting. This is my family just ticking along back then. Doesn't look like there's anything really wrong, does there? Except a couple of actually weeks before that picture was taken, I was diagnosed with stage 4 breast cancer. And I wanted to get these pictures taken quickly because I wasn't really sure that there would be so much more time to take family pictures. So we did that. So as I mentioned, in November of 2017, I was diagnosed with stage 4, which is metastatic breast cancer, called de novo, which means your first breast cancer diagnosis. And I always forget to tell the story, but I'm going to remember this time. How it was found is I got a routine bone density scan, DEXA scan. Many people at about 55, women particularly, get that sort of as a postmenopausal thing to determine where your bones, your bone density lies, so that as we get older, we tend to lose bone. We know if we've done that or not. We don't have that marker in time, then we don't know. So things were found in that bone density scan. One thing led to another: X-ray, CT scan, bone biopsy. 4, 5, 6 weeks later, the bone biopsy came back metastatic breast cancer, and that's how it was found. And before all that, I had a mammogram and an ultrasound, all clear. Got that phone call that we all want to get: all clear, see you next year. So clearly that was the shock of a lifetime, right? To go through all of that and think it was bone cancer or any number of other things, to find out that it was actually metastatic breast cancer. And I guess, Dr. Kinney, don't you call that an incidental finding?
Right.
Right, where you're looking for one thing, but you wind up finding, something else. So that's how my whole breast cancer journey started. And I kind of didn't even believe it, really. I was like, nah, this is all kind of messed up. I don't even really think this is right. So hoping, obviously, that it wasn't right. And so went to the Mayo Clinic, got a second opinion. And of course, they clearly confirmed and quickly the initial diagnosis that it was what they said it was. But it was there that I began to learn about breast density, what the impacts were, and how what happened to me can happen to so many other people, and has. And that kind of started the whole journey to what is happening now. But a year later, after that diagnosis, I decided to walk something called the Camino de Santiago. It's an ancient Christian pilgrimage. People of all religions, or not a religion, walk it, but it's an ancient Christian religion. And I walked 500 miles across the top of Spain, starting here in France. I'm walking all the way across. It took me 40 days to get over here to the cathedral in Santiago de Compostela, where supposedly the bones of St. James, one of the apostles of Jesus, is kept. And so this pilgrimage has been going on for over 1,000 years. But it's really meant for people to, contemplate and think, and, kind of figure themselves out and get away from their normal everyday being, and do something else. So I wanted to do that. And I also decided to raise money for a clinical trial that was going on out of the Mayo Clinic for a screening modality that finds a lot more breast cancers in women with dense breasts. So I wanted to contribute in that way. So I raised funds also while I did that. Actually wound up writing a book about it. The title is Probably Benign. I won't go into why I named that, but it's the first chapter of the book if you're interested. And you can get that at probablybenign.com, Amazon as well. And I really just wanted a different way to communicate to people what had happened to me. And I wanted to share about breast density and what all we could do about it, so that my story doesn't become anybody else's story. And that has kind of been what's fueled me ever since. So I came back, from that walk, and I wrote the book, and I began to speak much like this. I actually talked to a couple TTN chapters before My Density Matters, the not-for-profit, was even formed. But it got to the point where I was just speaking and talking and doing a lot of different things, and thought, I could do this better, bigger, if I formed a non-for-profit. And so we did that. So the mission is to empower women to find out their breast density and learn their options, and insist on additional screening. We'll get into more why we need to do that, but that's the mission of it. And so the vision is a world where breast density no longer hinders the early detection of breast cancer. So if we can imagine a world where things are better in the world of My Density Matters, that would be it. So what is breast density? What is it all about? Breast density is what kept my cancer from being seen. So this is a packed visual here. If you don't remember anything from this except for this, that will be good, because this is the crux of the whole thing about breast density. So here you have 4 different mammogram images of 4 different breasts, and they represent 4 different categories of breast density. So category A is a non-dense breast. It's made up entirely pretty much of fat, and fat shows gray and black on a mammogram. Breast density and breast cancer both show white on a mammogram. So the more density you have, the harder it becomes to see the cancer in the mammogram images. So as you progress from left to right, from category A to category B to category C to category D, which is an extremely dense breast, you start to lose visibility of the cancer. And that's what happens in real life. A woman who has a category A has very, very high likelihood of a cancer being seen in her breast. But a woman of category D, it can be up to 50% or risk. And this is one of the problems with breast density, is that you can't see very well on a mammogram. The second problem is that the higher your density, the more likely you are to get breast cancer. Isn't that a cruel twist? But true, and that exacerbates the problem. Not only can it not be seen well on a mammogram, you're also more likely to get breast cancer in the first place. 71% of breast cancers are found in women with dense breasts. So they're starting to do some interesting research on why that is. But I think we can kind of say, wouldn't you agree, Dr. Kinney, right now, we don't really know why?
Nobody has a definite answer. You know, the
Yeah.
biggest theory is just that there's more breast tissue instead of fatty tissue. And so it's just a matter of volume.
Matter of volume, yeah. And breast cancer, or almost no cancer, really starts in fat, right?
Correct.
It's always in an organ of some
In the breast
sort.
ducts and lobules, right?
Yeah, right. So this is the case. Adding insult to injury, unfortunately. So in many comparative studies, mammography found really less than half of breast cancers in women with dense breasts. And this is unfortunately true. And when I asked the Mayo Clinic, how in the world could this have happened? How can I be sitting here with stage 4 breast cancer when I had an all clear mammogram 2 months ago? And the response was, a mammogram can be like shining light through concrete in women with dense breasts. So light doesn't go through concrete. You really can't see through it. And that's the problem. But what the doctor also said to me was, this is not a failure of anyone, but rather this is a failure of our technology. Whoa, that was enlightening. Okay, so that was kind of like a light bulb moment for me, because I thought, well, we can land one of those rovers on Mars and have it walk around and talk back to us. You know, we can do many fabulous things. The military can land a bomb on my coffee table if they want to. And so if that's the case, then why can't we do better than this, finding breast cancer? Feels like we really technologically ought to be able to. And so I began to research that. Well, you know, why do we need to find it earlier? Well, the earlier the breast cancer is found, the greater the chances of survival. So this situation that we're in, where we're really not finding breast cancers as early as we could, is literally impacting people's lives. No two ways about it. If breast cancer is found at stage 4, which is distant in this graph, your 5-year chances of survival are, this says 26%. We might be up to about 30 now. So I guess I'm in the 30, because I've been alive 5 more years. But what we like better is stage 1 or stage 0, where your 5-year survival rate is really, really, really close to 100%. That's where we want to find it. Always. Because if we don't, you know, the later of stage of diagnosis, the more it impacts your life, all aspects of your life. Your social life changes. Anybody who's had a serious breast cancer or cancer any type diagnosis will tell you, it changes your social life, it changes your friends, it changes your spirituality. Maybe your occupation has to change. Financially, it can be devastating. Always, it can change you. It does. Financially, though, is very, very fascinating in that a breast cancer diagnosis at stage 0 or 1 or 2, yeah, it's expensive. But stage 4, as we go up, is, you know, north of $200,000, and I can vouch for that a year. I can vouch for that number because the drug that I'm on is $12,000 a month. Now, I have good insurance, but what if you didn't? Tough. And might I say that stage 4 is for as long as you live. It doesn't stop. So who wants to get there? So how do we find these cancers earlier? And here's what I'm going to turn it over to Dr. Kinney, because he's used almost all of these, if not something similar. So have at it, Dr. Kinney.
Okay. Well, these days, most women, when you go to the breast center, you're going to get a 3D mammogram. And that was instituted probably going back around 10 years ago, because the 2D mammography just wasn't clear enough to find some cancers. And so, you know, the data was saying this is a 40% improvement in cancer detection, and everyone was very excited about that. It's taking, instead of just getting 4 pictures with 2D mammography, you're getting, you know, hundreds of pictures. That's because it's going through the breast tissue kind of slice by slice. So the idea was to overcome that ability of the dense breast tissue to hide the cancers. So it's, you know, 40% improvement. We would all take 40% more of something in our lives for the most part, well, at least the good things. We'll leave the bad things for something else. But 40% is a nice improvement. Now, when you add some of these other technologies, you can see that we can still find more cancers. So obviously 3D mammography is not the be all end all. It's where you start. Really, none of these other tests, ultrasounds, MRIs, the contrast enhanced spectral mammography, which is the CESM or the MBI, those all basically come after the mammogram, because the mammogram is still your best screening tool. And you don't know, very important point that Leslie will probably mention again later, is that you don't know what your density is until you've had a mammogram. You can't tell by look, you can't tell by touch what your density is. You need the mammography, and kind of think back to the slides a couple ago that Leslie showed with all the different categories from fatty to heterogeneously dense, and very dense. So once you know the density, then that's a guide to whether you actually need some of these other technologies. If you have fatty breast tissue, completely asymptomatic, have a normal self-exam, have a normal doctor exam, the chances of finding additional abnormalities with any of these tests would be very small. When you get into having the dense and very dense tissue, then you need some form of these additional testings. And I have my bias on, you know, where to go with something like this because of my experience and maybe my current employment in a sense, but I'm not going to get into that. What I want to stress is that any of these are good things to add when you have dense or very dense tissue. These are the tests that you should talk about with your family physician, your gynecologist, when you get your mammogram report and find out that you have dense or very dense tissue. That's the point where you say, I'm not stopping, I want one of these other tests. And that may vary in your communities as far as what's available. Most places will have ultrasound. Most places will have an MRI. The abbreviated MRI is a newer technique that some places have, not universally available at this point in time. The contrast enhanced mammography, same story. It's a little bit more in the developmental stage. And MBI, it's located a little bit sparsely around the country at this point in time, although we hope to see some inroads in that and get that out there more. But you know, you're looking at, instead of finding 6 cancers in 1,000 women with dense or very dense breast tissue, the MRI at the bottom is finding 15 more cancers. Now that's specifically in a group of women who have high risk as well as dense breast tissue. In other words, they may have a genetic abnormality, or they have multiple family members who have had breast cancer, or they've had chest radiation for, say, a lymphoma in the past. So there are things along with the density that add to the risk level, and you know, MRI is the best tool in that situation. Data is pretty solid on that. But again, these are tests that are available. Some in some locations, not necessarily, it's not true that you're going to find all these in every hospital, not yet. But you can do something, is the point, with the technology that's out there, and not be satisfied with a mammogram report that says negative, come back in a year, you have very dense tissue. Don't stop.
Dr. Kinney, I have a quick question in that regard. If this kind of test is available, what is required? And it probably depends on your insurance and your state and everything else, but what would you need to justify in order to have your insurance pay for this additional testing?
That will vary from state to state. I think this group is predominantly from Ohio. Am I right?
Mm-hmm.
You guys are the lucky ones. As of September 15th, 2022, any of these tests are covered as long as you have dense or very dense tissue, abnormal mammogram, high risk situation. Your insurance must cover it. All you need is a doctor's order to get the test done. That's Ohio. We have 49 other states that need to catch up. Thankfully, there's some work being done nationally. Number one, to get the mammogram reports, what's the word I'm looking for here, standardized across the country, so that there's good wording to identify those women who have the dense and very dense tissue. Right now, you could get a mammogram and have somebody in Colorado look at it, somebody in Tennessee, somebody in Ohio, and they're just going to read it differently, but their final interpretation is going to be different. And it shouldn't be. It ought to be a matter of, you have dense tissue or you have very dense tissue, and you have the options of doing these tests to further investigate. And that's some FDA legislation that we hope to see finalized by early this year. And then there is a Find It Early Act that is being developed, was introduced late last year. I understand it has to be reintroduced into Congress now. But that will mandate insurance coverage nationally for any of these tests. We think there's always some loopholes and some legislative language that may, make it harder to do, or for insurance companies to sidestep around something. We're looking into those things. But we hope to have some standardization on the language so that everyone gets a workable report, and it tells them what else needs to be done, if anything, and then that they can have insurance coverage to get that done. So,
Yeah, we hope that comes through, and we hope the language is good, and we hope it's comprehensive, and we hope it's understandable. And we hope the insurance payment, act goes through. It might take a year or two. We don't know. The way that Congress operates is a bit of a mystery. The Congress is never going to vote on that by itself. It's going to get put in with some other massive set of bills, because that's just the way it works. So we will track that as best we can. So yeah, you kind of get the lay of the land of the situation, and I've got a little bit more information about the laws in Ohio to help make it clear for people in Ohio. So these MBI, abbreviated MRI, contrast enhanced mammography, and MRI all are, great modalities that find a lot more cancers than we do up here. And we want everybody's cancer to be found. So we're looking for this gap here. We want the gap to be filled so that everyone's cancer can be found earlier. These MBI on down, they all use a contrast. So you have to be injected with something, and they're all different things. Pros and cons, everybody's got their opinion, but that's the way they work. And that's really why they find more, is that they're a functional imaging modality instead of a anatomical view. Dr. Kinney, you want to say something about that?
I mean, I was just thinking in my head, it's always nice to have more tools in your toolbox, and that's what we have. I mean, if we want to have a better life, it depends on how you view that and what area you're talking about, but we can do better with the technology. We have the tools, and, you know, here's MBI finding, you know, 7 more cancers compared to 3D mammography. That's over 100% more. Or for the high-risk patients, 15 more cancers. Okay, that's out of 1,000 women. That means even with the MRI, you've got, what, 979 women who have no cancer. Great. They also can go home and sleep well at night. That's a very high level of assurance.
Yeah.
If there's no cancer there at that point in time. So we just got to get off the dime. I mean, we do CT scans for those who smoke to find cancer because it's better than a chest X-ray. We do colonoscopies to find colon cancer because it's better than a barium enema. Well, let's start doing more MRIs and contrast mammographies and MBIs because they find more cancers. And each of these does have their pros and cons. And, you know, like I say, I can't sit here and say, this is the test that you need to have. I'm just happy when somebody gets any of these done.
Yeah.
That's progress.
Yes, it is. This photo kind of just visualizes how it works. So this is the same breast at the same time. This is probably a heterogeneously dense breast, and you can see the cancer is right here, but in the mammogram you can't see it. But over here on the MBI, because it's a functional image, and you know the contrast goes to the cancer and lights it up, you can probably tell where the cancer is in this picture. And that's how they work. There was a study done by Doctors Brown and Covington a couple of years ago that estimates the number of, I'll call it lives saved, but they call it deaths averted for, you know, some technical reason. But the pea green shows how many lives would be saved if we used a technology like molecular breast imaging, in addition to this, which is a 3D mammogram, or the blue, which is a regular mammogram. At least double. So these are real people with little kids or parents to care for or careers to have or, you know, just lives to live. We can do better. So, you know, why are things the way they are then? You know, you have to ask, you have to listen to all this and say to yourself, well, why aren't we doing better then, if we can? And there are several reasons. So there's no standard recommendation or guidance other than just to get a mammogram. A mammogram is still the standard of care. So that's what most people are going to do. So what most doctors are going to prescribe, standard of care. That's what they do. That's what all the guidance people say. So there's no like, oh, in this case, you need to get this, or in this case, you need to get that. We're getting more and more of that, but there's no one guidance. And then
there just isn't enough education of the doctors at this point, is
Right.
really what you're saying.
Yeah, I am saying that. Yes.
You know?
Yeah.
And,
Mm-hmm.
you know, they go with the standard recommendations that they might see through their societies, but they're not fully aware of what an MRI, an ultrasound, or an MBI can do in addition. And so,
Yeah.
not
They
only
did
do
a
we have
survey
to,
of doctors about a year ago, and well over half of them thought a 3D mammogram and an MRI found the same amount of cancer. Not even close, you guys. And that's what they thought. So that's not to get on any one doctor's back. That's just to say that they have a lot of things to keep up with. They're probably not breast specialists, and there's a lot going on in every field. So part of what My Density Matters does is empowers women with this information so that we can then advocate for ourselves with the doctor. This is going to be the way it's going to go in the future. There's going to be less doctors per person. That situation is not going to get better. So we have to learn what we need to know and advocate for ourselves. And there's also, I think, that belief that's out there that this 3D mammography solves the density problem. It was kind of sold as that some years ago. And now we know that you can tell from the charts that we were looking at, that's not really the case. It's a little better. If you have the choice, get the 3D. But it does not really solve the problem. And I hear it all the time. Oh, I got that new 3D. I'm all set. Not really. Insurance payments has always been a problem with these additional screening modalities since, mammograms are alone still the standard of care. But Ohio, we're going to talk about this in a minute, but you are in good shape. And what Dr. Kennedy just really alluded to is the education and the understanding of how big this issue really is not really known by everyone. The subject of breast density has been around for years. It's always been a thing. It's just it started to have been talked about a lot really in the last decade, but they did a survey of 8,000 women in the United States, and only a third of them knew what breast density was. So I'm thankful for programs like this one where we can educate women as to, what it is that we need to know about and advocate for ourselves. A long way to go on that, if only a third of the women in the United States know what it is. And lastly, I think the mammogram story, like we've been told all of our lives, get your mammogram, it'll save your life. Early detection saves lives. And so when we get that clear mammogram report back, like I did, all clear, see you next year, we want to believe it. Woo, well, that's what I thought. Well, at least I don't have breast cancer. Know that. I might have something else, but I don't have breast cancer because they called me and said, all clear, see you next year. And that's a hard story to let go of. And I think it's part of the barrier to now finding out that, oh my gosh, what I really thought my whole life, is it true? Yikes. Don't like that. Ohio, you have a breast density and formula that's been in effect for some amount of years. And I took the law and just sort of broke it down into the basics for you guys. Women with dense breasts must be notified they have dense breasts. They don't particularly need to tell you what your level is, a C or a D. That is not required in the law. That's not to say that your particular letter didn't tell you, or that your doctor or your facility decided they were going to go beyond this and tell you what it is, but they don't have to. But it must mention that mammography can mask cancer and that density is a risk factor. So every state's a little different in, on what they tell you and what they don't have to tell you, but this is what Ohio says. Best of all, you guys just passed last fall a really good, what I would call maybe a model for the rest of the country, that passed last fall. Additional screening is covered if you have dense breasts or if that patient is at high risk. And you can be at high risk for a lot of reasons. It includes MRI, ultrasound, and molecular breast imaging. Your copay does apply. So that is Ohio House Bill 371, called the Breast Cancer Bill, if you want to Google it and have a look and read all about it. But this is the bottom line. And so, I don't know, just go Ohio, because this is pretty good. What's interesting about it is the status quo of this mammograms being the standard of care will still prevail. Because just because it's covered by insurance doesn't mean that your doctor knows anything or cares to prescribe it for you. It doesn't mean they have to. It doesn't mean anything. They may not even know about this law. But if you know about the law, then you can take it the next step. The status quo is hard to change. This guy is not going to push this rock over by himself. And this whole breast density issue is not going to change on a dime either. So what do we do? You, even in Ohio, still need to find out your breast density. And the only way to do that is to get a mammogram, as Dr. Kenny said a few minutes ago. So you, certainly in Ohio, your density should be spelled out in your mammogram report. We have a program at My Density Matters called Check Your Chart. And what we do is we empower women to get into their online portal, read their mammogram report, and learn what's in there. And we've got a series of videos and what to look for in your mammogram report to learn what your individual situation is with your density. It arms you with the data about you. So, and if it's still not clear, be sure to ask the prescribing physician. So we still have to find out. And then we learn and we advocate for ourselves. Learn your options, learn what the imaging centers around you have. Learn that, you know, if you think you want an MBI, you can go to Toledo and get one because there's one in Toledo. Is there any others in Ohio, Dr. Kenny, or is it just the one in Toledo?
Toledo and Youngstown at the Abdu Breast Center, I believe it is.
Oh, okay, got it.
We have a couple others who we hope to have soon, but those are the two active ones I can think of right now.
Okay. We do have on the website a directory for molecular breast imaging and a directory for abbreviated MRI. If you go onto the My Options page, there'll be a directory in each section that you can look and see where they are. Talk with your doctor, have that conversation, download some of our tools, go in there and have the conversation with your doctor. Be prepared that you might know more than the doctor does. You can research your imaging centers. Some people travel. Some people will go to wherever they think they need to go to get the imaging that they need. And just discover more. There's a lot of things on our website to learn about these different modalities. And you have to insist. Don't be deterred. Stand your ground. And be prepared and armed with information and download guides, take them in. You might have to use your outdoor voice inside. That's okay. That's what it's there for. And persist until you get what you think you need. Sometimes we need to make a statement by moving, and it's up to us to make sure that we are satisfied with our healthcare. So My Density Matters, you know, is ever expanding and doing more and more things to help get the word out to women everywhere. So just thank you for giving us the chance to tell you about it. So then hopefully you can tell other people about it and they can tell other people about it. It's kind of how, you know, how it works the best sometimes is word of mouth. But we do online and social media events. We were invited to be on Chicago local TV channels this fall. We're having a very, very large Find Out My Breast Density Today on, it's actually 2/22 in February. And please join us for that event. I can tell you more about how to do that. We were on an award-winning interview by Spotlight on America last year. So that video has made it quite around everywhere. And we're on we do podcasts and lives and more ongoing. We have a Latina outreach nationwide. We're doing a Polish event on International Women's Day here in Chicago. And we do corporate and civic engagements, much like this one, some larger corporations. We collaborate with the National Consortium of Breast Centers and Breast Cancer Wellness Magazine for our Check Your Chart initiative. We collaborate with the University of Chicago for our Latino outreach. And we do, on 2/22, we'll be doing a live with the Black Breast Cancer Alliance to try to reach different communities who have unique problems with this issue. So thank you. And please just follow, share, and support if you believe in our mission as much as we do. And tell your friends and family, have them go to the website, learn all about it. Join our mailing list. We don't sell your name. Only every couple of weeks. It's not a bombardment every day. If you would like to have an event like this one, reach out. We will do what we can to make that happen. Follow us on social media, help us participate and find out My Breast Density Day. You can go to the website to learn that. And if you feel so compelled, we would love your donation to pay for all the things that we need to pay for in order to go bigger, better, wider with letting everyone know this information. So I'll stop now and we will take questions. Are we back? Yes. Okay. Are there questions in the chat, or do we just want to go with whoever talks, or how would you like to do it, Carol?
If people just want to raise your hand, and unless we get overloaded, we'll start with whoever has the first comment or question. Looks like I see Joan Levy or Levy,
Levy's
and then we'll
fine.
go to Sharon.
I'm just curious at how do you find out what level of density your breasts are?
You want to take that one, Dr. Kinney?
Sure, that's going to come from your mammograms. That's why the mammogram is the key place to start. You find out your density, but it's also, you need the mammogram because it may find a cancer that all these other technologies can't find. And that is because of microcalcifications, and not to get into all the details, but you still need the mammogram for cancer detection. And obviously if the mammogram finds an abnormality, then you don't need to go on to that. But to know whether or not to go on to these more advanced technologies with the functional imaging, then you have to have that mammogram as a starting point.
Well, I've always been told I have dense breast, but nobody ever said it was fatty, scattered, heterogeneously, or extremely. And I usually get an MRI at the same time because they have followed things in the past. Thank goodness they didn't turn out to be anything, but nobody ever used any other definition or any other wording except dense breasts.
Right. And that's part of what we're hoping gets changed with some of the legislation, that there'll be more definite descriptions of what's going on in a woman's breast, so that you have more information to know what you're dealing with. I mean, the fact that they said that you have dense breasts, that's a positive. At least, you know, they didn't ignore that, and you were aware of it. And, you know, getting the MRIs on a regular basis because of having dense tissue depends on risk levels, other findings. It sounds like there were things that they had to keep following, and sounds like you're getting good care.
Is it true that that they're going to change that you can't get a mammography and a sonogram on the same day?
I think
Is that
that's a very
changing?
local thing. It's hard to say what's going to happen in Ohio versus Illinois versus California,
Mhm.
something like that. Can depend
I
on
have
your
some
insurance.
questions to ask. Thanks to your presentation, I have some more questions to ask.
I do
With my
think
doctor.
that it's helpful to have them on the same day. If you've got the history that suggests that you need to get them both, it's helpful for everyone. And the system loses people if they have to go back a second time. Like there will be a certain percentage of those people that don't ever go back for the additional, this is another day off work, it's another this, it's another that, right? So, you know, let's hope that people, including you, can get them scheduled on the same day if they know they need to.
Thank you.
It makes no sense to separate them, but I know it happens.
Right.
Thank you.
Did you have a question? You're on mute.
Yeah, my question was related to the last one. I didn't know whether there were objective criteria for classifying the level of breast density, or whether that was like a subjective appraisal of the person who's looking at the test results.
Yes and yes. It has predominantly been a subjective evaluation, meaning you could get 5 radiologists to look at your mammogram and 3 could say it's dense and 2 might say it's very dense. So there's a subjectivity. There is this little thing called artificial intelligence out there now. And there are several companies that are in the business of using that to more accurately or objectively identify the density level. So there's that transition with the technology. That's another area where things have changed in breast care to give a more objective measurement on
Thank
that.
you.
And Sue Garcia? You're on mute, Sue. Can Susie, can you unmute Sue? You can't do it. Sue, while you're unmuting, I'll move. Brenda, did you have a question?
I did. While we were talking, I went in and looked at my chart, and there is a density code listed on my last report. So I'm in Ohio. Was happy to see that. Second thing is, can you do anything to change your density?
Density will vary, probably more than anything based on age. When you're 25, not that you're getting mammograms at 25, but your breasts are more dense at 25 than they are at 45 than they are at 65. The main reason, menopause. So there's less hormonal stimulation on that. If a woman is on hormone replacement after menopause, that may maintain the breast density on that. So, but if you see your mammogram report and it says that you have very dense tissue, it's like, okay, what can I do about this? Nothing really. It's just a signal for you to be more vigilant, but there's nothing that you can do with diet or exercise or over-the-counter medications or anything else that's going to change that.
I think sometimes we give the message that having, dense breasts is bad, and it's good to have not dense breasts. I think that's not what we're trying to say. We're just trying to say that they're different. Like some people have black hair and some people have brown hair. Some people are short, some people are tall, some people are, we all have different anatomical makeups, and some people's breasts are denser than others. It's not a bad thing. It's just something that you need to know about, because
You do anything wrong.
You didn't do anything wrong, right? It just is what it is, and you just need to know what it is.
Like being short and tall, it's genetics for the most part.
Yeah.
Or know your blood type.
Yeah.
So, Dr. Kinney, I'm just glad you didn't say that you should drink less wine.
Cheers.
Okay, we'll go to Sue Garcia and then to Maureen and then to
Yes.
Joanne again. Yeah, Sue, go ahead.
Yes, I'm so glad I tuned in today because I had no idea that there was even a report available in my record. And that's a wonderful thing. But what I wanted to ask you, they usually said when I left the lady who was doing the testing, she said, "Oh, you have dense breasts." But, I never knew about this stage of density before. So that's another very important thing. But is this kind of a universal thing that the report in the data system will grade you like A, B, C? Is that going to be on that report, or is it just going to say your breasts are dense?
It varies from community to community.
Okay.
And
there's
from
no
state to state.
assurance. Okay.
So you really have to, as Leslie said a couple times, you need to advocate for yourself, which is true throughout anything in healthcare, in my opinion. But for this particular topic, you need to advocate for yourself. And if the report doesn't say that you have dense tissue or not, ask. Don't sit back. Find out.
this is part of the problem, and this is part of the confusion, is that some states have a requirement that it be one way, some states don't have a requirement, but some people in that state might go ahead and report it even though it's not a requirement. Other places don't. So this is what might be a really good result of this new language that the FDA is going to come out with, because then that will create more consistency across everyone.
Exactly, exactly.
It's not consistent now. So
Okay, Maureen, I think you're.
Yes,
had a-
I think that finding out the density is seems so important and so varied really surprises me. I went in and pulled up my chart while you were talking, and I pulled up my most recent one, and I was surprised to find out that Brenda and I are both in the state of Ohio, and Brenda got some kind of a density code, which I did not. This is what I got. I got the breast tissue is predominantly fatty, which I now take, thanks to tonight, means probably a lower density. But the only other mention of density in the report, it was related to previous breast cancer that I had several years ago in the same area where I had the cancer. But that's all that it said relative to density. And no one has ever spoken to me about density at all. And I've had lots of breast issues. So this has been very informative. Thank you.
Right.
well, interestingly for you, I mean, I don't know, but you may not have dense breasts, and maybe you never did. So that's why it was never discussed.
That could be why it was never discussed.
Yeah. And some laws will say you have to be told if you're dense, but if you're not dense, you're not told. So then
it's like, hey,
people who are not dense are like, I've never been told. Well, you
Yeah.
weren't told because you weren't dense. So it's confusing again.
Right.
That may
Yeah,
be
they should
where
have,
you
like,
fall. I don't know, but
negative or something. I don't know.
yeah. Yeah.
Add some category that says not dense or something so that
Yeah.
you would know, or someone would know.
Well, that's what A and B are.
Okay.
But again, if your facility or the law at that point in time didn't say they had to say A or B, then they didn't.
Right. So yes, so they're not. So I think that it's important this really brings home to me the importance of knowing this.
If it matters, mine is from Ohio Health, which I know a lot of people in Ohio do have.
That's what I have. I'm reading Ohio Health.
Yeah, and at the very bottom of the report, it's the very
Different
last
facility.
density code.
Well, you know what? I'm gonna have a talk with them. Then now mine was from April of 2022, so maybe the law wasn't passed then, and they didn't have to tell me anything.
Mine was before that, so.
All right. Yeah, I will have that discussion, definitely.
Joanne, I think you had a follow-up
Yeah.
question.
I did have a follow-up question. From the discussion, can I assume that that breast size has nothing to do with density?
Very true. Correct.
Okay. And then the other thing is, some of us are of a certain age and are probably on Medicare. I know this is a more general question. Is Medicare and the rules around breast mammographies, sonograms, are they national laws, or is Medicare different in every state?
Medicare is going to be more universal. And in some ways, I would tell you that right now, Medicare is ahead of Blue Cross, Blue Shield, United, Humana. The private insurers are lagging behind. I can get into reasons why I think that happens, but it's all about the Benjamins, as they say.
Another reason why we have to stand up for ourselves.
Yes.
Well, it was interesting. It was a little interesting because all the years that I've been going for my mammographies and sonograms, the physician comes in after the technician has taken the report and spoke to me. And then when I went just recently, when I made the appointment at a call center, they said because I was on Medicare, it won't be read for 24 to 48 hours. And that was repeated to me when I went into the office by the receptionist. And when I mentioned it to a physician, they said, I've never heard of such a thing. When I called Medicare, they said there is no such law on the book. That's why I asked if Medicare is more national, because it just didn't make any sense to me. I don't know if there's a lack of radiologists at this point, and that was being used as an excuse. But it was disturbing to me.
Strange to me.
Yeah. Thank you.
Liz,
for
Can I
answering the
respond to
question.
her?
Yeah, go ahead, Elizabeth.
Hi, I'm also in New York on Long Island. My mammogram was read right then and there the other day, but they said that I'm on Medicare. They said my sonogram, which I had at the same time, was not covered. I had to pay for that up front.
Mm,
Second time. And I get a
Well-
sonogram twice a year.
twice a year.
My mother had breast cancer.
I'm gonna say it might be because of twice a year. That's a little more frequent than standard, but obviously you've had it twice a year, but now they're saying no.
Right. They said Medicare is giving them a hard time now and they're not allowed to bill for it anymore.
It
Wow.
might be that twice a year story. The frequency
Dense
of it.
breasts and a mother with breast cancer. In fact, my 98-year-old mother just came up just this week. I found out that she has a lump. So we'll see.
Wow.
It's rough out there. It really is.
Leslie, didn't you a couple of years ago, if I'm remembering correctly, the presentation you didn't you use the phrase "be your own boss"?
Be your own boss. Be the boss of your breast cancer screening.
Yeah.
And it's not easy because of all these things that we've just talked about, you know? This is not, it's not an easy road, you know? Some insurance companies are different than others. Sometimes it depends on whether you're, you know, what your doctor says is the reason why you need the thing. I mean, there's a lot to it.
Yeah.
But we have to, until this becomes so taken care of that we don't have to worry about it anymore, we have to advocate for ourselves.
Well, here's one thing we need to do. We need to get more women in the Senate and more women in the House, because women will vote for things that protect women,
Yes.
right?
Great.
I second that.
Tends to be true. It does, it does.
Not gonna argue. I'm the only guy here.
Yeah, sorry to gang up on you, and Dr.
Sorely
McKinney, but
outnumbered, Dr.
you
Kinney.
get it. You've been working with
I-
women your whole life, so.
Yes, I have.
I'd like to ask a question.
Yeah, go ahead, Jeanette.
Well, I want to know if there's an age limit for when you should not get mammograms anymore.
That's something that's been thrown around, debated and discussed. And I think the predominance of opinions, there are society regulations, the OB/GYNs may say something different than the Society of Breast Imaging, that says something different than the American Society of Breast Surgeons. So there's all kinds of different standards out there. What I used in my practice, and I think a lot of people do, whether it's in the society regulations or not, is it's really kind of in a sense, a quality of life issue. If you're 45 and heaven forbid you have a terminal disease, you don't need a mammogram. If you're 75 and in good health and have a life expectancy of another 20 years, do a mammogram. So it kind of comes down to somewhere between, if your life expectancy is another 5 or 10 years, it's reasonable to do a mammogram. If, you know, whoever's mother was 98, I don't know if they've been getting regular mammograms or not, probably not. And I wouldn't disagree with that. But then when you find something, thankfully, that's still usually a pretty good prognosis at that age, just a more indolent type of cancer. But like I say, there's no set in stone answer on that age requirement, but I look at it as a quality of life. If your quality of life is good, protect it. Get your mammograms.
I don't know if you can hear me. Can you hear me?
Yeah,
I've been
go ahead,
having
Elizabeth.
trouble with my, oh, good. Okay.
Yep.
My name's Liza and I live in New Jersey and I'm in the New Jersey chapter of TTN. And this has been a great program. And I was looking at the latest report I got on a mammogram. And I didn't realize it said right on the report, I have heterogeneous density. And until this moment, I thought, so what? I had no idea of the significance of that. And a couple times, the place I go to, sometimes they always call me back for an ultrasound, which is discouraging me from getting regular mammograms because it's so terrifying. And sometimes it's the same day, and other times you have to go back on a separate day. I think it really varies in this particular location how busy they are. They'll do it both tests in one day if they can, and otherwise they call you back. And I think I didn't understand a lot of what you were talking that's been covered here and tonight. So I appreciate you having the session. And to me, it seemed like getting a call back was like torture. And why are they doing this? Is it really necessary? And now I can see that it's why it's called for. I do have a question between the 2D and the 3D mammogram. Is there a difference in how much radiation there is, or is there any downside to a 3D over a 2D?
There is a little bit more radiation with the 3D mammography, but nothing that is substantial, and it's well within the limits of what is considered acceptable radiation exposure on a yearly basis. So it's a safe test in that sense.
Okay, thank you.
I just had my mammogram last week. Again, Leslie, coincidentally, I think my reaching out to you is facilitating my getting things done, I guess, maybe. But when I had it, it was the plane she did the 2D and the 3D both in the same session. So, and I didn't realize that until then that there were the two different ones. And she said that they take them, right then and there, and then they compare and so on and so forth. But we didn't get into any, specific discussion about next steps because she was just
is that in any kind of normal practice, Dr. Kinney, to do a 2D and then a 3D that you know of at the same time?
I don't know enough about the actual taking of a mammogram from being a surgeon and not a radiologist. I don't know all the details. It's basically the same equipment with probably a little different software to do the 3D mammogram. So, your position's the same and everything is pretty much there. You're just getting more pictures with the 3D. Mm-hmm. And there are different ways of using the 2D to create a 3D or vice versa. But those are details I'm just not fully aware of.
Okay. Other questions, comments? We are recording this session, as you can see. It looks like, Liz, you have a question. Did you want to, Liz Anderson?
Yeah, hi. Sorry, I'm on my phone, so no camera. I was having technical problems, but you all are asking fabulous questions. So like everyone else, it seems, I pulled up my chart and it says that I have extremely dense breasts. I'm going to meet with the new OBGYN next month. So I am due for my next mammogram in July. So it sounds like I start the conversation from the place of, as I'm sure you see in my records, I have these dense breasts. Do I immediately ask for one of the better technologies, or is it required that you go for the basic mammogram and then work your way up, or how does that work?
you've already got a mammogram report that says you have very dense tissue. So I think you, today, tomorrow, next week, you have a legitimate reason to have additional imaging. You just need to know what's available. Most places are going to have MRI. Most places are going to have ultrasound. Some have MBI, some have the contrast mammography. Some of what you do also depends on your risk level. Again, and there are ways to calculate that your doctor might be able to do, and that can help decide which test is better. But yeah, I mean, I think at this point, you have a legitimate reason to discuss this with your OB-GYN and ask for some kind of additional testing.
So, Dr. So risk level is based on family history, age,
Yeah.
what else?
Yeah, when you had your first baby, when you had your first menstrual cycle. Oh geez, what am I missing here? There should be other things there. Family history is one of the more predominant things. Some of the newer models actually factor in the breast density. Older calculations did not. But these are readily available computer programs that can be pulled up. You can pull it up, your doctor can pull it up, and it'll tell you everything it needs. And they're not difficult questions. It's just put that information in.
I think last time, Leslie, you mentioned there's a questionnaire or something called the Gale.
There's a Gale model, which I don't believe even now incorporates breast density, but there's another one called Tyrer-Cuzick, which is two doctors' names dashed together who created the model, Tyrer-Cuzick.
How do you spell that?
I think it's Tryer.
That's a good start.
SACK. If you just did that Tyrer-Cuzick risk model, Google, you'd get it.
Okay, thank you.
One of the other big things is for the models would be whether you've had a previous breast biopsy and whether it showed anything of a precancerous nature, things of that, like that.
Okay.
Yeah.
Great.
Tyrer-Cuzick is the one that I think is most commonly used, and that does incorporate your breast density into the risk levels.
Okay, great. Thank you. That's helpful. Liz, did we get your question answered enough?
Yeah, and I'm just curious as follow-up. How does having children or not having children, or how many or how late in life, how does that factor into your risk for breast cancer?
I don't know that I can give you a specific answer about why, other than to say it must be hormonal. And typically, women who have their first child before age 30 have less of a cancer risk than after, if you have your first child after age 30.
Mm.
And that's just something that's been, analyzed through the years.
Breastfeeding, same way, right? That helps as well.
Hmm.
But it seems to be better if you breastfed and had kids in your 20s, which honestly most people don't anymore.
Not anymore.
Right? So
Sandy, I think you had a question.
He already answered it with breastfeeding.
And did you get your question answered about how to spell isn't Tom for that?
It's
one assessment?
Tyra what?
Leslie?
what was that?
The name of that assessment tool, T as in Tom, YRA.
Here it is. It's TYRER CUZICK. So you put that in, there's a risk calculator, you can pull it up and you can do that at home tonight.
Great. Thank you. Okay, are there any other questions, comments?
Well, I can make a comment. I had breast cancer in 2010. My breasts are very dense. They found it anyway. I had triple positive. So I had chemo and radiation and surgery, 2 surgeries. And it's like 11 years. And when I go back, Yeah, they treat me like a little princess, and I go up to the Cleveland Clinic in Cleveland, and they treat breast cancer survivors a little differently, like I think better. And when I have issues like the surgery site, you know, they'll do like a sonogram or whatever. And so I've had a couple of different tests, but now I've got to go find out what they were. I don't think I've had an MBI, but I'm going to find out for sure. And I really think this was very informative. And I knew a lot about breast cancer because I had it, but I still learned a lot. So I want to thank you both, Leslie and Dr. Kinney, for your information and for being here with us and sharing your information and your time and your expertise and yourself.
I wanted to mention that it is this session is recorded, and at some point, Susie or Donna will be able to tell us where it is and send the link so that you know, it would be just fine if you have somebody you want to share this with, because this is a good way to spread the word to people who weren't able to be here today. So, you know, certainly Leslie and Dr. Kinney have said, hey, you know, we're happy to do another session, and it's a great opportunity for people to ask questions and share things, of course. But just having this information through this particular presentation of want to record the word out to everybody else. I wanted to, before we close out, I wanted to remind you about Leslie's website. I went out to look at it. There is an abundance of information just on the website. And I made a personal contribution to her nonprofit on behalf of our chapter, just as a way to say thank you for taking your time today. And you and any of you who feel so compelled can do the same when you go out and look at her website. But at least look at it. It's got a whole bunch of information that also you could share with friends and family, just to educate them through all the stuff that she has on the website. So thank you again, Leslie. Thank you. Can we call you Michael?
Yes.
Thank you. Just, I feel so formal calling you Dr. Kinney all the time.
I'm not a very formal person.
Okay, good. Well, thank you both, Leslie and Mike, for being here today. It was really great. Appreciate it.
Thank you for having us. Really
Yeah.
appreciate it.
You.
And thank you, Carol, for bringing it.
Thank you.
Sure.
Yeah.
Thank you.
Thank you, all three.
And like Leslie says, be your own boss. Speak in an outdoor voice. Make sure you get what you need.
Thank you.
Thank you.